So my name is Javier Oesterheld, and I am the division chief here at Cancer and Blood Disorders program at Levine Children's Hospital. I've been here about 18 years. We are a program who does all cancer care. I'm also the Jeff Gordon Children's Foundation Endowed Chair for Cancer and Blood, and also the Vice Chair of Clinical for Levine Children's Hospital. My work in neuroblastoma started as a fellow, where I was in a basic science lab at Columbia Presbyterian, doing a little bit of work on tumor endothelial cells in that space. And then really, once I started my career here at Levine Children's, became the so-called expert locally on neuroblastoma. I've been following that disease ever since, and I am the person who sees all the neuroblastoma patients at my institution. We were really excited in 2020 when Naxitamab was approved by the FDA because we had a very large neuroblastoma population here that was really desperate to give this therapy outside of Memorial Sloan Kettering. And so one of the things that we did is we operationalized the administration of Naxitamab very, very quickly, actually within 4 to 6 weeks. And we recently published that in 2024 of what our experience was. And so one of the things that I found incredible about giving Naxitamab in the outpatient setting is that it really does take a big team to make sure that you do it right. Once you figure it out, it's great. And so in our publication, we really showed how you started from the want to give the drug, right? And so the need to give it outpatient, have the patient not have to go into the hospital. And then one of the biggest side effects of this drug is pain. And so we wanted to make sure we could manage that. And so our first patient actually was scheduled about 6 weeks out from when we started this. And we engaged our nursing colleagues, we engaged our pharmacy colleagues, our physicians, our advanced practice providers to really create this kind of enveloped team where the patient was at the center. And so we figured out our algorithms, which was pretty much, minute by minute, when we were going to give our pain meds, how we were going to take care of the patient, what we were going to administer prior. And that collaborative effort allowed us in a very, very short time to be able to ramp up to being able to give Naxitamab, one of the first sites actually that was giving it commercially in the country. We've given Naxitamab now well over 200 times in our outpatient clinic. We're incredibly excited about it. We have it down to a pretty much a science. And we moved very quickly, and we're taking about 1 to 2 patients a week in about 3 months. And so our first patients actually were patients of ours that were traveling to Memorial Sloan Kettering for the drug. And so in that publication, we showed what our pain management was when we would give narcotics, when we would give non-narcotic therapy. One of the things that we really liked is we have an integrative oncology team here. And so music therapy and art therapy and these things really became a big part of managing their pain. It's a very quick infusion, 30 to 60 minutes, depending on when you're giving the dose. And so if you can really distract children in that time frame, it became incredible. We found that after we got into a rhythm, we started actually giving less narcotics with some distraction techniques that were really great. Our nurses can now run 2 infusions at once. It's really very well done. And so we were excited about that. And I think the publication itself just shows what you can do in a center if you really commit to giving this medication to your patients. We feel like we took the bull by the horns and really maximized the administration of the drug. I think one of the most important things about our publication had to do with once we gave the drug, it was really important to get the team back together and debrief to really figure out exactly what worked, what didn't work, and tailor that, not a one size fits all. And I think that was actually the most important. And everyone's opinion was really valued in the room. We did our first few infusions. We made sure, okay, well, did we miss the mark? Should we have given the narcotic sooner? Should we have not given the narcotic sooner? So that was one of the big things. How did we pay attention to their blood pressures, which is obviously a big deal in this? I think the big thing is people get very nervous about giving this drug. We had a lot of experience in our infusion center giving phase 1 drugs and other agents. And so we felt really comfortable with that. But after each run, each cycle for every patient, we really went through that patient pretty clearly with what worked, what didn't work. And we tailored that over probably 3 to 6 months into what our standards are today. And so we're really proud of the fact that we very rarely give it inpatient unless we have to because of some other feature that the patient has, usually respiratory, to be honest. If they have any respiratory insufficiency, a lot of times we will do that inpatient, but it's very rare to happen. And so one of the things that I think in medicine in general is always important is you got to keep readdressing, right? You can't just keep looking at the same thing. And so as we work through this, which you can see in how we set up our algorithms, it had a lot to do with the input from a lot of different parts of our team, pre the patient, after the patient, and now getting to a place where we feel like we're a well-oiled machine. One of the things that we really pride ourselves at Atrium Health Levine Children's is outpatient administration of chemotherapy. We started it about a decade ago where we actually will give ifosfamide, methotrexate, some of these drugs that are historically given inpatient, outpatient. And we have found in this that our patients are exceedingly happy. We do depression screenings, we do lots of our patient-related outcome research, really to show that if the patient is at home, they actually do better. It's just frank, that's what it is. So when we started this with Naxitamab, that was the ultimate goal. The ultimate goal was we want you home and we want you home safely. And I think a lot of that collaboration with all of our multidisciplinary teams, that's what really changed things for us. And so most of these families have other children. Most of these families, the parents have jobs. They have to be able to continue to work. Unfortunately, your life does not stop because your child has cancer. And I think for us, we really take that to heart. And our family-centered approach, which many of our children's hospitals do, really pushes the envelope on how do we get you to live your life as normal as humanly possible, knowing it's not. And so outpatient administration, safely being able to go home, not being in the clinic all day, all of these things really made a huge difference. The siblings really like having their brother or sister home. The parents obviously like it. And I think as a community, when you're home, it just feels more normal. I know I've used that word a couple of times, but I think it's important to feel that way. I think one of the challenges, honestly, when you start Naxitamab therapy is the belief that you need to have all of this staff around the patient. I think when we started, it was very clear that you needed 2-to-1 nursing. And what I mean by that is 2 nurses to the 1 patient. A little bit had to do with administering the drugs, pulling up the drugs, being able to give them. Once you get established, it becomes a lot easier. And I believe now we've been doing this for 5 years and we're very experienced in it. And we do not all the time use 2-to-1 nursing, maybe with the first infusion just to make sure the child does well. But after that, you kind of get in the rhythm of how to do this. And if we're doing 2-to-1 nursing, we're probably doing 2 infusions at the same time. And I think that is doable. And I think as many institutions begin this journey, it's starting to not be so nervous because of the history of the drug. And if you start doing it more and more, you get into that rhythm where patients actually don't require a lot of medications. Their blood pressure stay fairly stable. And I think it's just repetition. And we've gotten to that place. And I think if you follow some of the algorithms that we've published, I think you'll get there too. I think the take-home message from Levine Children's is that you can do this at your institution. And you just have to have some thoughtfulness about how to do it. It's not as scary as it looks on paper. Really, once you do it the first time, people will get more comfortable the second time, even more. I think as long as you have a plan of how you're going to manage the pain, how you're going to manage the blood pressures, and how you're going to manage the follow-up for the days in between the infusions, I think is really crucial. And I think you can find all of that in the publication. But my real take-home message is you can do this and it's great for our patients, right? It's great for the patients to be at home and it's great for the organization and the institution to be able to offer this. And the biggest thing we hear is how great it is to sleep in your own bed, right? And I know that seems contrite and simple, but it really makes a difference when these children are 2, 3, 4 years old and even older, to be honest. And I think we get a lot of satisfaction out of that, of being able to send them home safely. And we don't have a lot of readmissions, honestly, with this patient population. And I think that's what a lot of institutions are scared of. If you have a good follow-up with your nurses or your patient navigators, if you have them at your institution and you educate your families of what they're going to feel like when they get home and how to address that, you can get through this pretty easily. And on top of that, the drug works. So it's pretty great.